August 6th, we have the Rutland Regional Medical Center hospital budget presentation. I'll ask Mr. Hengstler to swear in the testifying witnesses from Rutland, and then Ms. Fox, you can take it from there for your team's presentation.
Perfect, thank you.
That's some feedback there. Thanks. I'm gonna swear in anybody testifying for RMC. Here's how we'll do it. I'll administer the oath. I'll ask each person who is planning to testify to unmute themselves. Then please, in order, state your name and then affirm the oath. That way we have a record of each person testifying and that the oath has been administered. Do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalties of perjury?
So I do, Judy Fox, the CEO of Rutland Regional Medical Center.
I do, Jen Bertrand, CFO, RRMC.
I do, Kelly Watson, CNO, RRMC.
I do, Jonathan Reynolds, Vice President, Clinical Ops, Rutland Regional.
I do, Mitchell Baruti, Chief Legal Officer, Rutland Regional Medical Center.
Right, you've been go ahead.
Oh, sorry, go ahead, Mark. I was going to say, I should have mentioned this at the top. I have a hard stop I cannot avoid at 5:15 for another meeting, so we'll try and keep the pace on our end. If that's not possible, I may ask somebody else to finish the meeting because I can't miss a 5:15. But so anyway, thank you.
And you're good to go ahead with the presentation.
All right, thanks. We will try to be expeditious here to manage the time. So good afternoon. I am Judy Fox, the Chief Executive Officer and President here at Rutland Regional Medical Center. I'd like to thank the Green Mountain Care Board for reviewing our budget and the data that we have submitted and for allowing the Rutland team the time to provide further explanation. This is a challenging time for everyone involved, and we appreciate the opportunity to partner with state agencies and other Vermont hospitals as we consider transformational changes. Next slide, please. So with me today presenting, myself, Jen Bertrand, Chief Financial Officer, Kelly Watson, our Chief Nursing Officer, Jonathan Reynolds, our Vice President of Clinical Operations, and Mitchell Baruti, our Chief Legal Officer. Online, in addition, we have numerous members of our leadership and our clinical team, as well as members of our board of directors. We'll begin by providing a high-level overview of our budget, and then each member of the team will provide more detail. Rutland Regional Medical Center remains committed to delivering high-quality, affordable healthcare to Vermonters. Even as we face mounting financial pressures, in response to federal reimbursement risks, recent state legislation, and rising insurance premiums, we've taken a strategic, disciplined approach to our fiscal year 26 budget. Our priorities include protecting core services, expanding access to primary care-like offerings, improving administrative efficiency, and strengthening regional partnerships. All of this with a focus on sustainability, access, and affordability. While RMC does not employ any primary care, we are committed to supplementing primary care services. Our 2026 primary care service strategy includes the expansion of both behavioral health and substance use treatment services. The Westridge Addiction Medicine Center now offers a walk-in, open access model for medication-assisted treatment. This expansion reflects our long-standing commitment to addressing the opioid crisis and improving behavioral health access across our region. We are also introducing NeuroStar transcranial magnetic stimulation for adults with major depressive disorders, including treatment-resistant cases. This is a non-invasive, evidence-based therapy which expands our behavioral health services and responds to an urgent community need. In addition to enhancing efficiency through technology, we've improved diagnostic speed and reduced costs. RMC is invested in a state-of-the-art laboratory analyzer. This upgrade increases testing accuracy, cuts processing times, and lowers overall testing costs. An important step to aligning clinical excellence with fiscal responsibility. Additionally, operational improvements have also yielded significant results. Collaborating closely with case managers and our long-term care partners, we've reduced custodial patient stays from 10% of our volume to 2.3% of our inpatient volume. This serves to free up acute care beds where they're needed most, improving patient placement and reducing the cost shift from the loss of these patients to commercial insurers. You'll hear more about our access to care strategic investments and efficiency updates from Jonathan Reynolds, our Vice President of Clinical Services. And in terms of quality, Rutland Regional Medical Center is still dedicated to delivering high-quality, patient-centered hospital and specialty care, supported by data-driven performance assessments. While CMS star ratings offer insights into healthcare quality, they reflect data that lags behind current efforts by 2 to 5 years. As a result, recent improvements at Rutland Regional are not yet captured in our star rating data. With strong leadership and a long-term strategy, our RMC is making measurable progress, as evidenced by recent national recognition for excellence in orthopedic care, maternity care, and patient safety. Rutland remains committed to continuous improvement across all areas. Kelly Watson, our Chief Nursing Officer, will provide more information on our quality roadmap and transformation. Fiscal discipline and cost containment have been a focus in our 26 budget. We've embedded $4.7 million of cost savings into this budget and totaling $13.5 million in savings over the past 3 years. These efforts helped us limit our rate increase, easing financial burden on both patients and commercial insurers. In fact, the Green Mountain Care Board recognized our RMC's strong performance as our cost trend was the lowest in the state, with a compound annual growth rate of just 0.8% from 22 to 25 and projected at only 1.3% when we consider 2026. Despite disciplined planning, the impact of state legislation, and specifically H266, has been substantial and is a primary factor in our negative operating margin in our 26 budget. It's important to underscore that our RMC met the Green Mountain Care Board benchmarks even before implementing H266, and we continue to address our stewardship responsibilities. The financial strain in delivering and receiving healthcare in Vermont is intensifying. And this is true whether you're a hospital, a clinician, a payer, or a patient. Service lines like our cancer center and infusion services, which previously helped offset under-reimbursed programs, are now operating at a loss. While we remain committed to providing these critical services, we must continue to assess the long-term viability of all of our services under this current model. Our RMC will continue our efforts to balance access to care while addressing our cost structure and efficiency measures. Rutland will not seek any offsetting commercial rate increases to negate the reduction in revenue because of the cap on pharmacy charges. Rather, we will continue to look at our cost structure and efficiency opportunities in care delivery. Jen Bertrand, our CFO, will provide detailed information on financial assumptions, impacts, and results in our budget. To balance access to care with the Vermonters' concerns for affordability, we're actively pursuing regional partnerships. We're exploring shared service lines, resource consolidation, and transitions of care to lower cost settings. At the state level, our RMC remains engaged and committed to ongoing discussions about reference-based pricing and global budgeting, initiatives that could reshape affordability and payment models across Vermont. This work is also prioritized in our transformation strategy and will be highlighted in today's presentation. Next slide. As an overview of our services, our RMC, the second largest hospital in Vermont, next slide, sorry, remains independent. Our primary service area includes 60,000 residents. However, we've seen an increase in utilization of patients well outside our primary service area. Close to 1/3 of our utilization is driven by patients who reside in other service areas across Vermont, New York, New Hampshire, and Massachusetts. While we are licensed for 145 beds, our average daily census is 80, which is down 10 patients a day from 2024. The decline in inpatient census is multifaceted and largely positive, including a decline in length of stay, transition of surgical cases from the inpatient setting to the outpatient setting, and a significant decline in those custodial patients. On average, our patients stay slightly less than 5 days per stay, an improvement or reduction in stay of about 5%. To care for our patients, as the largest employer in Rutland County, we employ over 1,700 employees and credential 332 medical staff, of which half of the medical staff are employed by Rutland Regional Medical Center. RMC employs most specialty care in our community, dermatology and rheumatology being 2 exceptions. And as stated, we do not employ primary care. We operate a busy emergency room, which includes 26 general rooms, 5 of which are dedicated to psychiatric care. We have 5 surgical suites and 1 obstetric surgical suite. The efficiency of our surgical services can be measured by the fact that our surgeons use nearly 80% of all scheduled OR time. Performance at this level is considered best practice. In addition to ED and OR, we offer 13 ICU beds, a 4-room endoscopy suite, 4 sleep beds, 24 psychiatric beds, including 6 which we dedicate to the state for ICU psychiatric patients, both medical and radiation oncology, full offerings of women and children's services, laboratory services, including serving as a reference site for other healthcare institutions, imaging and interventional radiology, cardiology and pulmonary, and a whole host of specialty clinic services. To respond to the emerging needs of both our patients and our workforce, Rutland's senior leadership team, working in collaboration with our board, set a new direction for our RMC, modernizing our mission, our vision, and our values. Our mission to provide high-quality specialty care for all, coupled with our vision to be the preferred healthcare provider and employer, sets the bar high for both patient care and employee relations and serves as the foundation for our strategic plan. Next slide. Rutland Regional, our leadership team and our board of directors recommitted to a strategic plan in 2023 with the adoption of a 5-year aspirational plan. I'm proud of Rutland's strategic vision and our commitment to transforming the way we deliver healthcare and how we engage and support our workforce. Year 1 focused on building a strong foundation, while Year 2 is focused on achievement and advancement of goals. Year 3 will continue our commitment to the advancement of these existing goals while blending in new opportunities for healthcare transformation, regionalization of services, and further efficiency opportunities. Next slide. Our plan includes 5 strategies: financial stewardship, quality of care, access to care, employer of choice, and transformation. The 5 strategies are supported with 13 objectives and 14 high-level org-wide metrics and a multitude of milestone success measures. The program serves to guide and prioritize our work and has been a significant support in our recruitment efforts. Our management team will share both achievements and planned opportunities in each of the strategies. And now I'll ask Jonathan Reynolds, Vice President of Clinical Operations, to discuss achievements within our access to care strategy.
Great. Thanks, Judy. If you could hit next slide, please. So I'll be going through some highlights and successes, as Judy mentioned, within our access to care and quality pillars of our strategic plan. First up here that you can see is regarding our Westridge Center, their opioid use disorder treatment clinic that we have. A few months ago, we changed to an open access program. This was a really exciting step for us because this means that patients, when they come to the clinic and want to be enrolled, they can do so on the same day. Previously, these patients showed up and may have had to wait upwards of a week to receive their first treatment dose and be admitted. And as you can imagine, many were lost to follow up essentially over that period of time, not to be seen back at the clinic again for ongoing healthcare. And that was challenging. So since beginning open access in March, we've had 100% enrollment rate. And these patients come receive medication that same day. Really what this boils down to is that when someone has made the decision to begin treatment, we are there with arms wide open, ready to support them as best we can. This was a huge coordination effort by the team at Westridge, and we could not do it with without the passionate individuals that work there. You can see the patient quote at the bottom of the slide here that sums it up. Really, same day is what matters most here. And we are fortunate to have some great coverage through Channel 3 WCAX that you can see on the right hand of the slide here. Next slide, Moss. Next, I'd like to talk about some great work happening on our inpatient psychiatric unit. As Judy mentioned, we have 24 beds on this unit, 6 which are contracted with the state and 18 general. Additionally, as you know, CVMC closed their inpatient program this January, and we are certainly beginning to see the shift of these patients coming to our hospital for treatment, including from other HSAs. And really what this boils down to, as you can see in this graph here, is that over 50% of patients on our inpatient psychiatric unit are from outside the Rutland HSA. We also have some patients that have been here for a very long time, over a year, another approaching perhaps 2 years, and we remain committed to supporting them through their healthcare journey. We take pride in our psychiatric program here at Rutland Regional, as we're helping meet the needs of the state, here. Plus the next slide. Continuing the theme of mental health, we are investing in capital equipment called NeuroStar. I was approached by our psychiatrist about 16 months ago, asking for this treatment modality to be brought in-house here. Basically, it provides TMS, transcranial magnetic stimulation, which provides magnetic pulses to stimulate areas of the brain. This is used to treat treatment-resistant depression, which is a condition where depression symptoms don't improve after 2 different classes of antidepressant use. The most interesting part is that study shows a response rate greater than expected with other antidepressants. We look to go live this coming October, and to our knowledge, this service is not provided anywhere else in the southern part of Vermont. So we're excited to provide yet another treatment option for this subset of patients in our service area. Next slide. We also have a very strong and robust outpatient behavioral health clinic. This clinic has truly become cornerstone in supporting transitions of care throughout our organization as patients migrate from the inpatient to the outpatient setting. This reduces readmissions because we have the outpatient access to make sure we can get these patients in. As PCP access within the Rutland community has been challenging, this clinic has been extremely successful at also increasing their medical management of its patients to meet their needs. And to sum this up, as you can see in the last fiscal year, we had over 3,000 behavioral health visits within this clinic, and it really just shows our commitment to mental health care in the Rutland region. Next slide. Transitioning out of mental health, I'm going to talk here about lymphedema, which is a condition where the lymph system is disrupted and fails to properly drain fluids. As you can see in the photos here, this leads to swelling of the arms and legs and extremities. This can happen with oncology patients, post-surgical patients, as well as obese individuals. Chronically swollen extremities lead to quality of life impacts, but also other medical conditions. This can be extremely painful. It can cause stiffening of the joints. It can lead to infection, cellulitis, things like that. And the treatment is compression and manual lymphatic drainage. This past year, our director of rehab services identified that we were underserving this population of patients, and we were fortunate to bring on a dedicated lymphedema therapist who, as you can see in this graph here, drastically increased the access for these patients and the treatments provided in this group. There's no one else doing this in the community, and it's important because this also, as you can see at the bottom, decreased downstream costs with appropriate treatment and management of these conditions. This is just an example of how here at the hospital we can shift resources to meet the needs of our patients while decreasing downstream costs. Next slide. Here are some other efforts that we've made to decrease the cost of care. The first is regarding our chemistry and hematology analyzers. That's the first bullet there. These are capital investments that through upgrades increase the accuracy of the test, decreased retesting, and overall decreased costs. The second bullet here also speaks to the fact that we revised our respiratory panels. We moved from a 22 target 1 hour test to a 5 target 15-minute test. Really what this means is that clinicians get answers quicker while patients, it costs less for patients and to payers alike. We additionally have done a lot of work to reduce blood contamination rates that have decreased costs of care. Also in the lab, we also have brought in new testing for C. diff toxin that has significantly reduced the amount of false positives, also extremely costly treatment, and some significant work we've done in the lab. The last bullet here shows that our case managers have done phenomenal work in reducing our custodial stay census from 10% to 2.3%. This has been hard work in coordination with post-acute care teams outside of the hospital. Really what this boils down to is that patients are treated in the most appropriate effective setting. Excuse me. Next slide. And lastly here, for this part of my section, I'd like to speak a little bit more about the cost of care, but also convey that we were really recently recognized as a Blue Distinction Center Plus for orthopedic surgery, specifically in hip, knee, and spine surgery. Not only did we meet quality measures, but the plus indicator means that we, quote, met cost measures that address consumers' need for affordable healthcare. This is a result of efficiencies in the procedures due to cost controls with supplies through our GPO. However, this also includes hard work such as standardizing OR equipment, medication standardization, medication reduction, and overall decrease in OR times. The combination of all those led to a decrease in costs for these procedures. I want to recognize our orthopedic clinic surgeons, as well as clinical staff, data analytics, that all participated in reducing these costs, as it was a team effort. We're looking to apply these strategies to other areas of the hospital. And with that, I will hand it over to Kelly Watson.
Thanks, Jonathan. Next slide. Thanks so much. So I'm going to take us through the journey, our RMC's journey to improved quality. So yes, our CMS star rating started to decline toward the end of 2022, and we were definitely very disappointed. But it didn't define us then, and it certainly doesn't define where we are going with quality outcomes. We faced a perfect storm during the timeframes from which the CMS star ratings were pulled. It wasn't just COVID, but it was multiple contributing factors, including changes, many changes within our senior leadership team, as well as a key vacancy in our quality department with no quality director for over 6 months. Like any strong organization, we took accountability for the decline and we responded quickly. Next slide. One of the first things we did on our journey to improved quality was hire an experienced quality leader, and we began to redesign our quality governance structure. We were intentional in that quality needed to be at the heart of what we do, and it became a main pillar in our then newly developed strategic plan. We also designed a quality outcomes dashboard to track and trend our data. The same metrics that contributed to CMS ratings were included, and we use it to make targeted decisions around improvement efforts. Next slide, please. While our star ratings include data up to 5 years old, our current performance is something that we are very, very proud of. Significant improvements in falls and pressure injuries are just 2 examples of our improvement effort success. We've also been working closely with VPQHC, and they were so impressed by our quality outcomes dashboard that they asked us to present it and share it with healthcare quality leaders throughout Vermont and New York. Our quality dashboard has become a model for real-time data transparency and a tool that helps us drive improvement. Next slide, please. Our improvements and accomplishments aren't just about the numbers, though. The quality improvements are also reflected in a variety of ways by various organizations. We're a 3-time magnet organization, designated facility rather, and we're currently pursuing our 4th designation. We have been awarded numerous recognitions for surgical care, maternity care, overall patient safety, and as Jonathan mentioned, Blue Distinction Plus in several of our orthopedic services. Our commitment to ongoing quality improvement is not just a goal, it's a reality for us at our RMC. Thank you.
Thank you, Kelly. So I'd like to spend a few minutes on how we reinvest in our community and our partnerships. We know that innovation and collaboration are key to our transformation strategy, which includes goals to partner to stabilize the Vermont healthcare system and to engage in payment reform. We know that collaboration with our local community partners and our state and federal healthcare agencies are vital. We have formalized our partnerships through board representation, committee collaboration, and engagement in state work efforts. Our strategies support the work that the Green Mountain Care Board and the Agency of Human Services are spearheading that relate to transitions of care, risk strategies, and the regionalization of services. Examples of this work include a focus on expediting transitions to hospice care, a focus on ED high utilizers, as well as evaluating payment reform opportunities and risk-sharing models. In addition, we continue to explore regional partnership solutions and efficiency opportunities. Specifically, we are pursuing targeted clinical partnerships with regional hospitals like UVM and Southwestern Vermont to optimize service lines, share resources, and reduce duplication of high-cost specialties. We are working in collaboration with the Agency of Human Services and the Rural Health Redesign Center to better define and realize these opportunities. We will begin to explore a shared EMR solution to reduce long-term IT costs, enhance interoperability across the region, and better support shared service arrangements. We will engage in the state's work group on long-term risk sharing to evaluate a joint approach to risk sharing and a statewide hospital funding pool. We are actively engaged to advance regional service planning through initiatives such as VAS and Kaufman Hall expense review and the Rural Health Redesign's regionalization of care model. Slide. In alignment with our RMC's strategic plan and the Oliver Wyman recommendations, our RMC engaged a consultant to assess opportunities for both access and efficiency. While decision-making is not yet complete, early indications demonstrate opportunities in how we manage efficient care delivery of ICU services, expand surgical services, invest in new technology, and promote sharing of services both clinically and administratively. These opportunities, along with others, will be a focus as we collaborate with other hospitals to consider regionalization and or sharing of services. And now I'd like to ask Jen Bertrand, our Chief Financial Officer, to take you through the detailed assumptions and inputs in the budget. Jen?
Melissa, if you could advance a couple slides for me. Good afternoon, members of the board, Green Mountain Care Board staff, and the HCA team. We certainly appreciate the opportunity to share our proposed 26 budget with you today. Next slide, please, Melissa. To begin the financial portion of our presentation, we did want to outline the starting point of our budget process this year. So prior to the legislative changes, which obviously did have a direct impact on the budget we're presenting to you today, our initial 26 budget was originally developed with the goal of achieving a modest but positive operating margin, one that we had intended to support financial sustainability while continuing to prioritize patient access and affordability. And although the originally budgeted margin was below our initial internal target, the resulting budget still yielded a positive operating outcome. That original budget also met the 3 benchmarks established by the GMCB and integrated the enforcement adjustment that we had related to our 2023 performance. And Melissa, let's advance. When H.266 or Act 55 passed, we quickly pivoted to incorporate the impact of that legislation into our 26 budget, which we estimate that impact in revenue decline to be around 11.5 million. 11.2 million of that is outpatient. And we do have 300,000 of it in inpatient. And I'll talk about the inpatient piece a little further on here in the presentation. And that's applicable to 9 months of our fiscal year. This created obviously a negative operating loss, approximately 5 million, 4.9 million to be exact, which is obviously an identified budget risk for us. One that our board is going to expect this leadership team to thoughtfully address once we have a little bit more time here to dedicate to closing the gap. Next slide, please. At the onset of every budget process that we go through, we always try to begin by defining our goals for the upcoming budget year, and our 26 budget certainly incorporated the balance of several objectives. One was to ensure preservation of services, such as infusion and cancer treatment programs, as Judy had alluded to, as well as increase the availability of services, improve access to care. And in this year's budget, as you heard both Judy and JR mention, we had a focus on primary care-like services. Another goal is to produce a budget that considered patient affordability, one that is incorporating initiatives aimed at reducing costs, both at an administrative level as well as operational level, and one that focuses on continued operational efficiency. And then lastly, ensures a commitment to our employer of choice strategy. Next slide, please. So just to summarize our 26 budget proposal, we wanted to highlight that our RMC is, of course, meeting all the benchmarks set forth by the board after the implementation of H.266, but did want to call attention to the chart that outlines the benchmark comparison of what we had originally planned with our budget, as we did intend to meet those benchmarks, as I mentioned. So we are under the benchmarks. As you can see there, we're at net revenue of negative 2.5%. Our commercial rate growth in aggregate is at negative 4.4%, and our expenses are at 2.82%. And we did want to notate that we included that 23 enforcement action into the budget, which is actually embedded in our rate. And I'll discuss that list of revenue improvements as part of the utilization section. Next slide, please. We want to provide a quick update on our FY25 projection because we have had a material change with regard to one aspect, which I'll explain further in the next slide. But as for our utilization, we have been experiencing a decline that's going to carry forward into 26. One area of note is our facility-based pharmacy volume. That's decreased. That's in relation to that reduction in inpatient census, since that's been underperforming to expectation by approximately 11%, as well as we've seen a shift in the mix of infusion drugs that we've administered. And then additionally, our second CT volume estimates reflected honestly an aggressive approach to expansion, which did not fully account for some real-time scheduling constraints. So in our projection, we've refined those assumptions a little more accurately to reflect that capacity going forward. And lastly, as it pertains to our utilization, provider vacancies have certainly impacted our surgical and endoscopy services, and we do anticipate those will recover in FY26, but we are seeing that decline in our projection currently. From a net revenue perspective, however, we are projecting an increase in our projection, and some of the primary contributing factors are favorable ACO settlement activity. That second being the reduction in custodial volume Judy was mentioning. And then third is RMC's receipt of a volume decrease adjustment. And if you could advance the slide, please. So in August of last year, we did apply for what is referred to as a volume decrease adjustment with CMS. This was relative to our FY 2020 cost report. We call it the VDA. That's customarily sought after once a hospital receives their final notice from CMS. known as an NPR or Notice of Program Reimbursement. And you could wait anywhere from 3 to 5 years after a cost report is filed to receive that NPR statement, hence that delay in timing. But the parameters under the VDA will allow a hospital that's experienced a volume decline that is outside of its control, greater than 5% compared to the prior year. And you can file for additional reimbursement. And that's really intended to cover the shortfall that's associated with a hospital's fixed costs being spread over fewer discharges. And during that time frame, during COVID, our RMC experienced about a 14% decline in discharges, rightfully so. That was during the COVID pandemic. So therefore, a large portion, though, of its COVID relief funding was applied toward lost revenues, or excuse me, expenses versus lost revenues. So that actually qualified us even more so to apply for this VDA. There is approximately $1.5 million, though, of PRF funding that were applied toward revenues, and we're in the process of evaluating that. The total amount that we did request from CMS was around 10.6 million. And did want to let the board know that in June of 2025, we did receive notification from CMS that we would be awarded $10.5 million of that VDA reimbursement. And it's also important to note that we have not received the actual cash for that just yet. It does always take a little bit of time, but we anticipate that will happen by the end of fiscal year 2025, hopefully. Next slide, please. So with the VDA, net of the estimated potential repayment of that PRF funding would essentially net us down from 10.5 million to 9 million. And that's the amount that we've incorporated into our net revenue projection. That would place us just below the 1% threshold set by the board. Obviously, a budget adjustment request might be prompted should we exceed that threshold. The impact of this will obviously be determined here later in the fiscal year. We only have 2 more months of the fiscal year. But with our current revenue trends, we're anticipating coming in just below that threshold. And really the retention of that VDA funding is truly essential for us. And we want to utilize those funds to preserve access to 2 critical rural healthcare services. And I'll talk about those in the next slide. Thank you, Melissa. It's our interpretation that there is a provision of H266 that really would allow the Green Mountain Care Board to consider a quote unquote off ramp for impacts to sustainability of rural healthcare services. We are asking that the board consider RMC applying its VDA funding toward the support of those 2 critical service lines that have been really impacted primarily by that H266 change. And that's, of course, infusion and oncology. Those 2 services, as Judy mentioned earlier, have really shifted from a positive to negative operating margin performance as a direct result of H266. And that calculation, it's resulting in a loss of about 11.5 million, as I mentioned, for the 9-month period of 26. And the VDA funding would actually offset all but approximately 2.5 million of that loss that we would either need to absorb or obviously address that additional loss through margin improvement initiatives. We are not proposing to redistribute any kind of rate pressure elsewhere in the system. This request does not involve recovery of lost revenue through any charge master increases or additional rate increases. And we certainly believe that's a fiscally responsible approach, using a non-recurring funding source to temporarily stabilize critical services rather than pursuing price changes that could affect patient affordability or even payer projections. And so really trying to preserve that access to care for Vermonters. Next slide, please. We did outline some budget risks. I don't want to review all of them. A lot of them were included in our narrative, but I want to highlight a few just with regard to the implications of H482 or Act 49. Our financial reserves, we've been deliberately and responsibly designating them for essential obligations, one of which is a balloon payment that we do have to pay within the next several months, and some scheduled debt payments that we have. We do plan to use investment funds for the purchase of capital versus us taking on financing at a higher cost. Also considering, lenders are becoming a little more cautious when evaluating hospitals in Vermont taking on new debt. And we are beginning to set aside cash for a future ERP and EMR transition, as Judy mentioned earlier. And so as it pertains to S126 or Act 68, we obviously support efforts to improve affordability for Vermonters, and we realize that stabilization of our insurance market is certainly needed. However, an additional $100 million in funding from hospitals should take into consideration any embedded efforts that may be put forward in this year's budget. And specifically for us, I'll discuss this a little bit more in the presentation. We did embed about $4.8 million in additional relief between reduced expenses and utilization potentially coming in lower than maybe the payers had anticipated in their premium filings. Another risk with our 26 budget are the impacts of the OBBA. That's going to have a direct impact for us on bad debt and free care. Right now, we're in the process of evaluating all of the changes within that bill in order for us to estimate those impacts. And also, we do have some processes that we're going to have to update to accommodate other non-healthcare related impacts from the bill, such as payroll related changes. And then lastly, there was limited time, as you heard me mention, ahead of our submission deadline to really thoughtfully establish margin improvement initiatives and try to address that negative margin. So we've looked at several mitigation strategies that we're currently evaluating and exploring. And one is an in-depth analysis of our cost structure. Another is service line performance and sustainability review, exploring strategic growth opportunities, leveraging the Kaufman Hall cost assessment that's been initiated by BOZ, and then just a further detailed review of our discretionary and administrative expenses as well. Next slide. Now we'll transition a little bit here to the revenue section. One more, please. And we'll begin with utilization. And although, as you've heard me mention, there's been a bit of a challenge with our utilization trends, we have incorporated several increases to service lines. Thankfully, we've been successful in filling provider vacancies and attracting new providers in orthopedics, endocrinology, cardiology, pulmonology, optometry, and sleep medicine. We've included revenues that are associated with the new NeuroStar treatment. We've incorporated the anticipated trends we've been experiencing with the expansion, of course, of our Westridge Center. We did add 3 OR days per month to the surgical schedule, and that additional time will accommodate that new cervical provider joining our RMC here soon. And then other noteworthy utilization changes we've incorporated into the budget is an increase for radiation therapy. And we also have increased demand for mammography and PET CT services. Next slide, please. We've also incorporated downturns that we've been experiencing in our current projections. So we've rolled those into the FY26 budget. Those will be volume reductions related to 2 provider vacancies in particular, that's neurology and urology. And then due to the decline in inpatient and outpatient volume and that downstream impact that's had on our facility-based pharmacy revenues, we've incorporated that decline into the budget. And then lastly, as you heard me mention about the CT volume assumptions, we certainly recalibrated that into the 26 budget. So just to make sure that we're coordinating alignment with the scheduling of our CT volume. Due to the addition of 2 new providers, or excuse me, those new list of providers, we were able to recognize a total increase of net revenue as it pertains to utilization of about $1.8 million. Next slide, please. Just to touch on custodial patients, you've heard Judy and Jonathan talk about this, and we've certainly drawn attention to this in our past presentations. And of course, those custodial patients are those waiting for placement in a more suitable care setting. And throughout the course of 25, there's been a lot of successful measures that have reduced that custodial volume. One is long-term care bed availability that's opened up in our surrounding area. Another is increased willingness from out-of-state facilities to actually accept Vermont Medicaid patients. So that's certainly helped improve discharge throughput and the care transition. And of course, that targeted effort by our case management team, that's really been instrumental in securing timely discharges. And then because of that increased access to long-term care resources, we've really been able to reduce unnecessary utilization within the organization. So in our 26 budget, we are anticipating 2.8% of patient activity. Right now, we're experiencing that 2.3%. But we did want to make sure in our projection and in our budget that there's a little bit there. And so we anticipated 2.8%, obviously much less from the 10% that we've been experiencing, not more than 18 months ago. Next slide, please. Just want to touch on patient affordability. We certainly take patient affordability into consideration when we're setting our budget, especially in our charge increase each year. We know healthcare is expensive. We're really trying to make some concerted efforts to only pass on increases that cover inflationary impacts. Even prior to H266, as you heard us say, we did not incorporate the 3% commercial increase into the budget. And payers may have anticipated in their filings that the hospitals were going to come in with the full amount. And instead, we had originally incorporated, it was an aggregate increase of approximately 1%, and we didn't exceed 1.4% for any commercial payer, and that's in accordance with our 23 enforcement. So we're really trying to strike that balance between patient affordability and that need to cover those inflationary impacts. Next slide, please. Moving on to our charge increase, we had an aggregate charge decrease in this year's budget of 3.55%. We did include a 2.3% increase in our inpatient and outpatient charges. And because of the H266 implementation, we have an 8.1% decrease in outpatient pharmacy. And we're not applying a charge increase to our professional charges. So the total decrease accounts for just over $33 million in gross charges. And obviously that impact of the pharmacy reduction counters that charge increase that we're applying to in and outpatient. I did just want to mention that even though inpatient pharmacy charges were not part of that H266 legislation, we do have a constraint within our EMR system. It doesn't allow us to isolate inpatient drug charges separately from our outpatient within our charge master. So therefore, we are absorbing a bit of an additional estimated net revenue loss of about that 300,000 I mentioned early on due to that limitation. Next slide, please. Just quickly here, just recapping, our net revenue budget does reflect a 2.5% decrease over our 25-month budget. I just want to remind the board that our starting point in accordance with our budget order is $345 million. So that net revenue decrease is, of course, related to that impact of H266. And so our total revenue decline from the 25 budget order of $345 million is about $8.6 million. Next slide, please. We did want to highlight and call out that we do differentiate between three categories of commercial revenue: in-state, out-of-state, and our own RMC self-insured plan. Our self-insured plan comprises about 9% of our commercial revenue. Our out-of-state commercial plans are approximately 38%, and then our in-state plans account for approximately 53%. And we realize that GMCB's rate review does focus on that in-state and exchange plan product side, and that out-of-state plans, they do benefit from the rate growth cap. And now that impact of H266. It is applicable, though, to mention that the other 47% I just outlined does not have a direct impact on the Blue Cross reserves. And we are actually seeing a shift from our in-state to out-of-state plan coverage from both a payer mix and utilization perspective with two of our commercial payers, major commercial payers. Next slide, please. And you can see that here in the chart too, that shifting between a couple of those pairs to that out-of-state utilization and payer mix. But as it pertains to our commercial rate growth, we are obviously, because of H266, well below the 3% benchmark. Our commercial rate reflects a reduction across all of our commercial lines of business. The aggregate commercial rate decrease is 4.4%. And I did want to mention again that our original budget would have allowed for that 1.4% commercial rate growth. After that pharmacy legislation was enacted, we did not recalibrate our charge structure at all. We simply removed that 2.3% increase on what was applied to pharmacy charges and imposed that additional 8.1% reduction so that we were in compliance with the 120% of ASP. We did not redistribute, we did not reallocate increases to other areas to offset that decline in revenue, and we wanted to make sure that we were aligned with that legislative intent. Next slide, please. As you heard me mention in relation to S126, our budget does reflect a bit of a level of embedded financial relief to Blue Cross Blue Shield of Vermont beyond that requirement of H266. We do have lower than anticipated utilization and a modest payer shift. Both of those collectively reduce revenue expectations aside from any rate increases. And our commercial partners often interpret hospital rate requests as inclusive, not just rate, but also that mix and utilization. And based on public filings and just some historical assumptions, we were reasonably inferring that premium requests might have been built around hospitals pursuing a kind of an all-in, if you will, 3% growth. And so our budget submission, however, has a decline in utilization and a slight decline in that payer mix. And we did a calculation to estimate that decline in claim activity would equate to approximately a $4.3 million reduction to Blue Cross. We do want to acknowledge that in our narrative, we did originally estimate that at 3.3 million, but after further analysis of how the enforcement was applied to our 25 budget, we recalculated that, and that was where the 4 million had come into the new calculation. And then, of course, we do always pass on additional savings of not needing any allowed expense growth. That allowable is 3%. We came in under that 3%, of which we calculated as approximately an additional $500,000 savings there. Next slide, please. Just to quickly highlight our uncompensated care trends, we provided a couple of statistics here in the slide. It's clear that uncompensated care is increasing, and the majority of that increase was attributed to the Medicaid disenrollments that we've been seeing. But it's also notable that this could further be impacted by the changes under the OBBA. I did just want to mention that. Next slide, please. Okay, segueing into other revenue and other categories of our budget. Next slide, please, Melissa. I just want to spend a moment on other revenue. I'll go through these quickly in the interest of time. Our 340B contract revenue projection does include an amount that we do not anticipate is going to continue in 26. There was some retroactive script eligibility and retroactivity to our payments for 340B. However, offsetting that, not going forward into 26, we're hopeful that the 340B legislation that was written in H266 is going to be recognized by the manufacturers, and our calculation is about that same 1.3 million amount. So we're hoping to maintain flat 340B revenues going into 2026. Next slide, please. Just quickly, our baseline other revenue budget assumes that additional increase of 2.8 million, I should say, between those two factors, 340B carrying forward. And then also we have an increase that we've been experiencing in our projections and trend for our retail pharmacy revenue. And we anticipate that that's going to carry forward into FY26. I will say from a budgetary risk perspective, though, with recent executive orders, that could have further impacts on Medicare reimbursement for 340B hospitals. So we're really monitoring that pretty closely. Next slide, please. Actually, we could go forward a couple. Thank you. Now to just quickly review expenses, our expenses are increasing by 2.8%. About 60% of that increase is related to salary and benefits. Our expense budget includes an overall cost of living adjustment of 3%, benefit expense increase of 3% as well. We do incorporate an increase for our 340B matching contribution. We've been a bit behind in the market, so we're trying to still work our way toward more of a market competitiveness with our 403B match. And then lastly, just to mention that our retail and 340B pharmacy expenses are increasing, which is obviously commensurate with that revenue increase that we talked about. Next slide, please. In this slide, we did just want to highlight a slide that Fremont Care Board staff actually presented back in February as the guidance was being reviewed and updated, as Judy mentioned, that showed RMC had demonstrated the lowest cost growth over the last 5 years. And we obviously anticipate that trend to continue into 26. Slide, please. Again, we've incorporated several cost-saving measures into our 26 budget. That amount, as Judy mentioned, is about $4.7 million. We really had some concerted effort to reduce our reliance on temporary labor. One aspect of that is leveraging our resource staffing pool so that we can have better optimization and efficiency in terms of our traveler staffing. We're adjusting staff to the decline in our budgeted census, obviously, and then we do have a minimum hour requirement as part of our collective bargaining agreement for per diem staff. So that's also helping to reduce that reliance on temp labor. As outlined in our narrative, we do plan to reduce our interest expense budget to budget by making that balloon payment that's associated with a 2013 bond that we have. And then also, even though our FTEs are increasing by a net of 7, we did incorporate targeted FTE reductions to offset that growth and manage overall staffing levels. And we also reduced our OneCare participation fees so that it's reflective of the 9 months of savings, since that's not carrying forward into calendar year 26. And then lastly, we did reduce overall admin expenses. I'll talk about admin expenses a little bit more here by $610,000. We acknowledge and recognize that there's certainly more work to be done there with regard to our admin expense, especially as we're trying to focus on those margin improvement initiatives to mitigate that $4.9 million loss. But even since our budget was submitted, I do want to mention we've reduced a VP position. We've actually redistributed those duties to myself, our CNO, and our chief legal officer. And also, since our budget was submitted, we just received 2 resignations in the marketing and development department. That's about 1.5 FTEs, and we will not be rehiring for those positions either. Next slide, please. As I mentioned previously, we incorporate just a calculation to understand what our cost saving initiatives are doing when it comes to our commercial rate and reducing that commercial rate request. And as you can see there, over those last 3 budget cycles, we've reduced expenses through cost saving initiatives of $13.5 million, and we've reduced that commercial rate request by approximately 8.5%. Next slide, please. I want to spend a little bit of time, not too terribly much, but a little bit on administrative expenses. And we highlighted this last year and just wanted to reiterate that admin in general in the cost report and as it's on the face of admin in general does contain other departments that frankly deliver what we call patient support throughout the organization. And there's also organizational operating expenses embedded in that line as well. So just as a quick reference, that does include quality and safety, our community health team, case management, and the others that you see listed there on the slide. And we certainly evaluate admin expenses through a lens of what we consider, let's call it truly admin. And we tried to, in the next slide, provide a crosswalk of that breakout of admin that we kind of monitor on a regular basis and consider, admin in nature. And this will certainly be, Melissa, can you move forward? I know there's a delay with it. There we go. That this will be an area of concentration for us as we focus on those margin improvement initiatives. But as you can see from the table here, when we categorize the admin expenses, it represents about 7.6% of total expense. And within what we call that adjusted administrative and general expense category, we have been able to decrease expenses by about $877,000 going into the FY26 budget. But that is offset by increases in security investments. Obviously, that's to better protect our staff and our patients within the organization. And we did invest a bit in our scheduling team to make sure that we're meeting those scheduling demands of our patients as well. So that's offsetting it and how we arrived at that 610,000 in the cost saving initiative slide. It is also worth noting that we have been doing a very thorough review. We're in the process of that, all the expenses that are hitting these departments. Historically, we have found that there have been some expenses that do belong in clinical departments or other expense categories as well. So we've been going through that process and we'll continue that as we go through in our margin improvement initiatives. Next slide, please. We did just want to quickly highlight our cost per adjusted discharge because this has been an area of focus. We've been diligently working to reduce that over the past couple of years. And prior to H266, we certainly have been doing what we felt was a reasonable job in trying to keep that cost per adjusted discharge in line. Next slide, please. From a personnel perspective, as I mentioned earlier, our FTEs, it takes a minute, sorry, are increasing by a net of 7. And you can see from the chart here, though, on the left, we've been very consistent in not only managing that FTE growth, but also that separation between clinical and non-clinical staff. I think that summarizes the expense section. If you could advance one more slide, though, I do want to talk about executive compensation for just a moment. We did want to just point out and highlight that RMC does not offer variable or incentive compensation to the executive team. We do benchmark executive salaries to the 50th percentile of similarly sized organizations. And I do think it's important to note that in smaller organizations, members of the executive team may wear, we call it many hats, as we refer to it, but have an expanded scope of responsibility outside those traditional job titles. As an example, when I mentioned earlier that we eliminated a VP position, I took on total rewards, which is compensation and benefits. Our CNO, Kelly, took on organizational development and training, and our Chief Legal Officer, Mitch, took on labor relations and recruitment. Just lastly, in an effort to make sure we're aligning with Vermont's healthcare reform principles, we did make the decision to eliminate cost of living increases for the executive team in the 26 budget. Next slide, please. Actually, we can advance to. We just want to touch on the margin and our bond covenant compliance here quickly. So our original budget, again, we were yielding about a 1.8% gain in margin. Because of H266, obviously, that changed where we ended up in this budget. And so we're at a negative 1.4%. And so we will be taking time here over the next few months to really develop some mitigation strategies to certainly address that negative 1.4% margin. And I do just really want to highlight, we do plan to use cash reserves if we are not able to mitigate the full amount and full impact of that margin loss to support that operating loss. Next slide, please. From a bond covenant perspective, we are in compliance with all of our bond covenants. However, it's important to point out with a negative margin in 26, we are starting to reflect a weakening financial position compared to benchmarks when we look at those. Not too long ago, we were in breach of our bond covenants. We really spent the last 3 years trying to stabilize our balance sheet. But unfortunately, that recovery has only really been achieved through suppressing our capital spend. And so on top of that slowdown that occurred throughout COVID and our financial issue that we faced back in 2022, it's really impaired our ability to reinvest back into the capital needs. And as you can see from the chart at the top of the slide there, our facilities infrastructure is certainly aging significantly, and we need to really make some meaningful progress on this. And that's why in 25 and 26, we're making some very significant investments in capital. Next slide, please. One more. Just really want to touch on our capital budget here quickly. We, as you heard me say, have deferred capital investments. We've really reached a point where we cannot continue to underinvest. It's just not sustainable. And I'll speak to the funding sources in a minute. But we again do plan to fund capital with a drawdown on our investments for both FY25 and FY26. And we're truly trying to avoid adding any borrowing costs or interest to our expense base. Next slide, please. This just highlights some high-level categories of capital spend. We have some larger planned capital initiatives that are exceeding $1 million. About 67% of that in 26 is going toward those 8 projects you see on the right-hand side. And then the rest is really primarily associated with much-needed equipment purchases. And then at the bottom, again, you can see the funding sources and what we have planned for funding in FY26. One call out I think that's important is we've been very fortunate to receive about $1.4 million in fundraising activity toward our linear accelerator and our PET-CT scanner. And I think this is the last section here, my last slide. Melissa, if you could, one more. So just quickly to summarize our budget discussion, I did want to state that the budget we're proposing we feel is responsible. It's thoughtful. We're trying to make sure we're considering patient affordability, and it's dedicated to improving access and preserving services in our community. Try to include those cost-saving initiatives and leverage some operational efficiencies, and incorporates some of those strategic planning initiatives that are set forth by our board that's committed to obviously providing high-quality care. And our other aspect of this is certainly to meet the benchmarks set forth by the Green Mountain Care Board. And I think that ends the presentation portion of our hearing. And Sheriff Foster, I believe I'll turn that over to you.
Thank you very much, Ms. Bertrand and Ms. Fox. It appears to be a very responsible budget, and we appreciate the efforts that you've taken to submit it and the information you provided. I'll turn it to the board members for questions. I'll start with Dr. Merman.
Hi, thank you, team. Let me just get set up slightly here. Okay, I'm going to try to be fairly quick because I think we're getting late on time. So a few questions just from the presentation. Thank you, it's really well organized and really helpful. With this volume decrease adjustment, you said that's from the FY22 cost report?
2020.
FY2020 cost report, great. Okay.
Correct.
So if you were getting money and you're saying you're going to use this as one-time money to offset the H266 Act 55 implementation, what is your future plan for offsetting that continued reduction in pharmaceutical price?
Well, we're still kind of working through what our future plans may be to mitigate that. And we hope that we can partner with the state on some creative ways around reference-based pricing, obviously participating in the Medicaid global budget process. But we can't sustain a negative margin year over year. And that's essentially what H266 is going to be creating. But we recognize that there are operational efficiencies and areas in terms of admin expenses that we can focus on and try to mitigate there as much as possible as well. But that may not overturn what we're calculating to be a year over year impact of about $16 million roughly when you apply that to a full 12 months. That's just going to be difficult to try to address that type of loss year over year, even with some of those other initiatives.
It does. I think we're all in for a challenge to figure out how to move towards more affordability in the state. So one other question I had on your budget, does this budget include or integrate the proposed settlement agreements that has been sent to the board within the budget, or would that change the budget thereafter?
No, that has not been incorporated into the 26 budget. I think you might be referencing a letter we sent this last Friday. That would have an increased impact to our bad debt and free care. We did propose increasing our 100% discount to 400% of the poverty level, as well as an additional approximate $1 million in reduced pharmacy charges, and that would not have been incorporated into the budget you're seeing today. That would be additional on top of what you're seeing today.
Okay, thank you for that clarification. The $4.3 million reduction to Blue Cross Blue Shield Vermont that was mentioned in that slide, for what is that, for the FY26 time period, or is that aggregate over a longer time period?
No, that's FY26. That's the utilization trend downturn that we're anticipating in 26.
And that there was a mention of that in the narrative, that you were expecting decreased utilization of Blue Cross Blue Shield patients at Rutland. Can you expand why you think that? Are you reducing access, or is this a payer mix shift?
This is the payer mix shift. What we're actually seeing is a shift to out-of-state Blue Cross plans, and that could be just shifting in the availability of businesses within our community as well that are maybe going out for national plans versus in-state plans. So that's the shift that we're seeing. That's a bit anecdotal, obviously, but we are seeing a shift in our numbers.
Okay. Sorry, a few more from the presentation. 340B program. We just have had presentations from hospitals over the last today and yesterday concerned that they could lose their 340B status due to an SSI adjustment. Is that something that you are concerned about or have had notification of?
We are actually in good shape with our SSI portion of that. There's a calculation for PPS hospitals. There's an, I'm sure you've heard the 8%, and then there's an 11.75%. But we are holding steady at just over that 11.75%. So currently we are not feeling like we are going to lose that status.
Okay. And the last question I have from the presentation, I have a few more questions, is you mentioned mitigation strategies that you're going to work on over the upcoming time period. And would you consider cutting low margin or negative margin services as part of that mitigation strategy?
Yeah, I'll take that one. That is part of our plan. We don't have necessarily any services in mind as of yet, but we do feel we need a disciplined approach. But I would say we would tie that with our work with other community hospitals and UVM around regionalization of services so that our community doesn't go without service, but can we offer it and structure it to be a little more efficient?
Okay, and of course, you know, we would want to hear of anything like that. I think with the reverse CON rule development will be helpful for clarifying that.
Yes, understood.
You had mentioned in the narrative and then also today that Blue Cross Blue Shield historically has interpreted this rate request to be all-inclusive, including payer mix and utilization. If that were the case, and you have reducing BCB-SVT patients, would you then maintain the same revenue from BCB-SVT?
No, and that's why we show that decline in revenue from them. So that would be incorporated into our projections into the 26 budget.
Okay.
That 4.3, Dr. Merman, that I mentioned, that's embedded in there. That decline is already in our budget now.
Okay. I think that we, at some point, should try to, and not today, but unpack this relationship that I think we're, I think there's concern on both sides that the rate that the board has set sort of like includes utilization and payer mix, and I think we have viewed that at least as a, especially within Rutland, as a change in charge over the years, and maybe this year more clearly a commercial rate that does not include utilization. So I think that there's both sides seem to be feeling that the other is including this as almost a global payment, but we should not for today, I think. Okay, there was a mention looking at the rate decomp sheet. It looked like there's a pretty sizable increase in Medicaid professional revenue that I think is related to increased utilization. The way I read that, does that sound accurate?
That I don't have that in front of me, but that does sound correct, directionally correct. And we have been seeing, yes. So there's two things that could be playing into that. In the total Medicaid line, if you're, I'm hoping you're looking at the total Medicaid line because we're having that shift from ACO to traditional Medicaid as well. Yes. But also just from, you heard Jonathan mention our Westridge Center. And a lot of that is predominantly Medicaid patients, same with a lot of our behavioral health services as well. And so we are seeing that increase in Medicaid.
Okay, that makes sense to me. I was wondering if that was the case. Also in the narrative, you discuss your community benefit as being $57.5 million, and then you broke out a chart which has about, it's on page 12, has about $12 million, I believe. So what's the remaining $45 million of community benefit?
Oh, that's the bad debt and free care calculation. That's part of that and part of the upper section of the 990 filing in Schedule H.
Okay.
So the delta there is just the customary calculation for support of the Medicaid shortfall and bad debt and free care.
Okay. I thought there was $24.7 million of bad debt and free care. So the rest is the Medicaid shortfall.
I'm sorry,
Medicaid shortfall. When I looked at another chart, I thought 24.7 million in bad debt and free care. So it's bad debt, free care, Medicaid shortfall, and then this $12 million.
Well, keep in mind, this is aged. This is 2023. Yep. 990 information because we had not filed our 2024 and we're looking at the 26 budgeted free care. So yep. Unfortunately, as you know, the 990's aged, and so that's the info we have in the narrative.
Okay. We
have since filed our actually we're about to file our next 990 here in 11 days.
Okay.
9 days actually.
Busy season.
It is.
What's the $9.9 million in RRMC provider practice investment?
So that is the investment for our specialty practices. That's reflected in the 990 on that particular line. So if you look at an income statement in totality for our provider practices, you would see we don't like to call it a loss. We call it an investment of $9.9 million. But of course, that is offset by any downstream revenues that our specialists are bringing into the organization. But that is part of our filing on the 990 is that investment in our specialty care.
Okay, I think I understand that. You, it was in Q16 of the workbook, but I also think you put it up in a slide of the how you were considering the administrative positions. It was on that slide. You had a line for revenue integrity as $1.7 million or 5%. Is that all of revenue cycle?
No, revenue integrity also includes some operational expenses in that particular line. And this is where it goes to us really kind of forensically going through so our collection agency amount is sitting, it's about $500,000 of that sitting in that particular line item. And that's org-wide expense there. So Hopefully that helps. But the revenue integrity team is the folks that are in charge of our charge master, revenue analysis, et cetera.
And so what other, so would you add to that to get revenue cycle, or would you, I'm sorry, there's $500,000 that's in there that's not, I'm trying to figure out if that's your whole revenue cycle.
It is not. No, patient financial services, coding, scheduling, registration, prior authorization. There's a multitude of departments that are considered revenue cycle.
Okay.
Some are more patient facing, as you can imagine, our registration team, prior auth team, et cetera. Same with our billing team. Our financial counselors are enveloped into that as well.
Okay. I'll try to read through that more.
And any questions you have, we're more than happy to answer and provide detail if you need to after what we consider a revenue cycle in its entirety.
I may send you some of those. Board question 20 regarding the Medicare star ratings of 2. You discussed the national downward trend of star ratings during this time, but my understanding is star ratings are based on a normal distribution and are relative. Can you explain your understanding of the downtrend, the national downtrend during this time?
I think what we were trying to communicate there is that when you look at the 2 to 5 year lag, that healthcare organizations across the country reported struggling with some of their quality outcomes. And so some of their outcomes that they had previously been at 5 stars, they dropped to 4. So I think that's what we were trying to communicate there, is that, across the nation, there has been a trend, if you will, of people reporting that their outcomes weren't where they once were before.
Yep. Okay. But then wouldn't the whole distribution of the star rating then shift down?
Well, as I mentioned in our presentation, we acknowledged that there were multiple contributing factors to our decrease in star rating. And it was not just, COVID. There were a number of factors that contributed to it.
Okay. And I actually really appreciated the presentation and the clarity and what you're doing to work to improve that. And it seems a significant commitment of the organization. So that came through in your presentation. I think that's all the questions I have for now. I may send you a few written questions, but thank you so much.
Member Teachout, if you have any questions.
Good afternoon. Thank you. I have a few, hopefully not too many. I wanted to start first with other operating revenue, and I think I have this correctly, but let me know if it's not. It looks like it's about 17% of your total revenue. And often I looked over some history over time, it seems to come in higher than budget. And I was wondering if you could just talk about what's in that line and why it would be maybe more variable than or hard to project.
So other operating includes 340B, retail pharmacy, cafeteria revenue, grant revenue, and there's a multitude of other smaller revenues associated with that. Any variability in there could be grant related. Obviously, our retail pharmacy this year had been outperforming what we anticipated in the budget. So the variability can be in certain grant lines in particular as well, because we may receive some grants that we've applied for throughout the year. So that's obviously not predicted in our budgets sometimes. I think I could give you further detail if you'd like, but that's really the top categories there.
No, that was perfect. Thank you. Just helps me give a flavor for what's in there. What makes up the difference between what you're estimating for your operating margin, the negative 1.39, and the total margin, which you think will be at 2.03?
So our operating margin, I apologize, is $4.9 million of negative operating margin. And so the swing in the total margin would be our assumption of our investment activity. going into 2026. And we try to predict, I want to say, don't hold me to the number, but it's always around the ballpark of 5% gain on our investments. So it's probably in that range. I could get you the exact number.
Okay, and your investments are your reserves,
Correct.
your capital reserves.
Yes, and that obviously is going to change going into 26 from some of the activity we've seen in our past because we are drawing on those funds now.
Thank you. And then in the presentation, you mentioned a Kaufman Hall expense review. Can you talk in a little more detail about what you're expecting, your timeline, and if you've built any of those sort of anticipated savings into your budget, or if these are future sort of goals?
Yeah, sure. So as commissioned by the Hospital Association, Rutland is participating in a statewide review. We have yet to see our results. As we are, those avail themselves, we will determine what expense reductions we've already included in our budget, and I expect that some will already be there. And then there will be other opportunities. Some of those opportunities may be very singularly focused within our organization. Others could be in partnership with other hospitals as we think about cost sharing, regionalization of services, and those types of things. We are participating with AHS as they set up their statewide 5 regional work groups to assess some of that opportunity.
Thank you. And is that where you would also include any changes for what I know was in S126, which gave incentives for telehealth for hospitals that were also supposed to look for future savings, but I don't know where that is at this point yet either.
Yeah, sure. So we do provide telehealth services primarily within our behavioral health service line. Because we don't employ primary care, telehealth is not a tool that is as beneficial because of the lack of those primary care services. Not to say there aren't other opportunities. And as we look at our care delivery and modernizing that, those would all be considerations as we move forward.
Great, thank you. I would like to return to the slide. I think it was before or after the one about Blue Cross and Blue Shield of Vermont. I'm a little confused by that slide, but you also had one where you talked about out-of-state insurers. And I was curious where you fit in your analysis, self-funded Vermont employers such as the state of Vermont employees or teachers in your breakdown of those.
Those are in
categories.
state. We categorize those as in state.
Okay. All right. Because they're self-funded. They're not ACA.
Correct.
Okay.
Yes.
All right.
It's more those national that you saw there, the employees of national companies that are seeking services within our state.
Right. Just this one's a comment. Even if you're an employee of a national company, you may still be a Vermonter. And we care about their health insurance costs as well.
Absolutely.
And the second sort of question I had is, you're assuming savings to Blue Cross from this, and it could be to any insurer. You just called out Blue Cross, but if they're losing members and losing premium because people are moving to other kinds of coverage, is that a savings to Vermont's system?
What we're seeing is a migration to that out-of-state plan. So essentially, yes, because that's going to the national plan product. If it was just shifting in state, I would say no.
Great, thank you for that. And then I'm going to jump to executive comp. You clarified that you don't give incentive increases, so therefore the base pay targeted at 50% truly is 50%. Do you give other merit or other types of incentive?
We don't do merit based incentive here. It's a cost of living adjustment. We will
Okay.
evaluate market shifts and look at that, because if the market's moving considerably, we want to make sure that we're calibrating to that. But we don't have any other added bonuses or changes to our comp.
Okay, so the 50% is 50 percentile.
Correct.
Great. And then I think my last questions were around, well, I have two more. So you talked in your narrative quite a bit about different areas that you were expanding services and coverage, presumably because of needs in the community. I noticed they were outpatient endo, ortho, mammo, pet, radiation therapy, and then the NeuroStar. These all seem to be services that generally have a pretty good commercial return, with the exception of your discussion of mental health and your expansions in the mental health category. How are you determining where you need to do these expansions?
So I can take that. So we track wait times for all of our services, whether you're waiting for an imaging exam or waiting to get into our OR. So by and large, we use wait times to determine where we are having opportunities or our patients are waiting too long. Just to correlate back to surgical services, in my comment, we use about 80% of our scheduled OR time, which is significant in terms of our performance and our efficiency. But what that means is we're really risking availability for add-on and cases coming through our ED during normally scheduled times. So we have tried to address that as well. We are seeing increases in oncology, and that is just a national trend that we are responding to as well.
Thank you. So then my last question was about the charge master increase. So you specifically have the 2.3% for inpatient, outpatient, 0% professional. And then I really appreciated the explanation of how you were handling the hospital administered drug pieces. So the average, I just want to clarify. So what you're saying is the effective commercial change in charge as a result of all that is the 3.55?
Not just, that's across the board. It's not just commercial. Our change in charge from a gross revenue perspective is that negative 3.55%.
Okay. So it's different net, obviously.
Yes, yes,
Okay.
absolutely.
And what would it be net? Did you provide that? And I'm not
We
saying
did
it.
in the
Okay.
rate decomp. In aggregate, it's negative 4.4 reduction in net revenue, specifically to just the commercial rate portion.
Okay, thank you. Struggling with all the different locations of
It's okay.
the information. I believe that was all for my questions. If there's anything I forgot, I'll have the staff send it to you. Thank you.
Thank you. Member Holmes, do you have any questions?
I just have a couple. Yep, thank you. Appreciated the presentation and the high quality submission. Very complete, clear, internally consistent. I really appreciate that. And I appreciate all the efforts that Rutland is doing to preserve access to essential services and facing these financial headwinds. So much appreciated. I know you're doing hard work there. I only have a couple questions actually. A lot of my questions were asked and answered. So thank you for that. One is really just about pricing strategy. Particularly, I'm interested in this as you're thinking about potential reductions, maybe in some low margin services. I know they're contemplated to try and close the revenue gap. You don't know where they might be, but it sounded like there might be some, coming down the pipeline. And I'm wondering a little bit about pricing strategy and whether you align price with the value of the underlying service, like an essential service being high value. How do you think about that when you're pricing rate increases?
Sure. I'm trying to think through. I mean, we always compare everything to the national percentiles in terms of our pricing strategy. I'm trying to think of, evaluating that a little differently with those lower impacted service lines. But I might have to get back to you on that one, just to be
Yeah,
honest.
no, I appreciate that. I mean, part of what struck me about it was I was looking at your high and low margin services.
Mhm.
And, MRIs and CTs, 1,500% of Medicare, right? I mean, that's really high. And every year, the relative markup over Medicare has been increasing on those services. And then you have some, your low margin services, that are actually priced below Medicare. Like, let's just take psychotherapy, 45 minutes, it's priced below Medicare. And so as I think about, what's a high margin service and what's a low margin service, and I also think about the underlying value of those services, I begin to think about your pricing strategy and how do we, I guess, why not allow allowable rate increases to apply to low margin essential services so they are less vulnerable to potential elimination?
Well, I think one piece of that in how we think about affordability too is that some of those services might be more prevalent in terms of access by maybe lower income individuals as well. And so we try to think about that piece of this. And frankly, as you know, there are services that are offsetting the cost subsidy to some of those. And that's historically been, unfortunately, how healthcare has been structured. And so, we're obviously trying to look at that now as we go forward, and why we've been presenting a lower charge master increase over the last couple of years as well. But I think one of the things that we talk about as a team when we're looking at setting pricing from that perspective is honestly, we want to be mindful of folks who can afford healthcare and what does that look like for them, which is why we don't increase our professional services either, is because we try to keep that static, so that we're not impacting people that are seeking services in our practices, which is pretty prevalent, as we can imagine.
So I would just add on to that. We know our charges are high, and we have embarked on plans over the last handful of years to try to begin to, decrease some of those charges. We're not where we need to be yet. So our focus is really around how can we deliver the service cheaper, instead of trying to always go back to rates and charge master. A great example of that is our eye care service, which is critical to our community, and it's a growing service, but it's a service that loses a fair amount of money. So our focus there is changing the care delivery model. We still offer the service, but how can we do it a bit more efficiently? And so I don't know if that helps or not, but we've tried to change our strategy on relying on rates and focusing on care delivery efficiencies.
No, I appreciate that. And it does help me. I guess two follow-up questions from that. Is there some upper limit on what, a reasonable markup over Medicare might be? Like at some point you're just stopping, as I'm looking at MRI spine, it's increased is there any kind in your pricing strategy, is there any upper limit on that?
Well, we try to look at price transparency amongst our peers. We try to look at benchmarking information to the median of pricing. So we do try to assess that in our pricing methodologies, obviously. But as Judy said, there's certainly work there. I'll be honest, we've been doing some modeling when it comes to looking at pricing from a different lens through reference-based pricing methodologies, and we are developing maybe some percentages that could be more aligned. with the methodology, but we're not done with that work just yet, but we are looking at that and spending quite a bit of time behind the scenes, looking at what, is it 250%? Is it 275%? And what does that look like so that we can maybe bring that down in other areas, but equalize in others?
No, I appreciate that insight. My other real question just is, or it's really more of a comment, and I understand that the no COLA increase for exec salaries is an attempt to align with state affordability goals. It didn't sound like you were planning on introducing variable pay. I do believe, and I would defer to the lawyers who read statute more closely than I do, but my understanding is that the board is required to ensure that all hospitals actually include some variable pay that's aligned with state health reform goals. So just wanted to put that out there, it may need further exploration. And yeah, I think that's it. So I'll pass it on and thank you for the presentation.
Member Walsh.
Thank you for the presentation. You've taken real steps, behavioral health access, cost discipline, quality improvements, and still facing financial headwinds. I think it's a tough spot. What would you like the board to understand most about your financial position and the current pricing environment? What would you like us to understand?
Good. I'll take it, and then maybe you back on that. I think we certainly agree with the board, the legislative activity, that healthcare is not affordable. It's expensive. The issue is that, as I said to board member Holmes, this has been a deep-rooted structure that has been in place for hospital and healthcare for decades now. And we certainly want to do our part to try to change the methodology and participate in alternative payment models. That's why, no matter where I have worked in this state, I have certainly been a huge proponent of value-based models, as well as looking and exploring alternative things in the market. We're talking, about the Medicaid global budget. We're doing some homework, as you heard me say, on reference-based pricing. But taking quick action is definitely hard for healthcare organizations, as you see in our margin. And so we're trying to do our due diligence to bring that back to at least a break even. But year-over-year experience of this is going to be very difficult. And we recognize we need to find efficiencies. We need to evaluate administrative costs. Those are all the things that we are definitely diving deep into that and making some headway, but not as much as we want to. And I think some of that pricing structure change quickly is hard for us to pivot, to be honest. And I'm acknowledging that. But we certainly want to be creative and how we're looking at this going forward. And if there are alternative models out there, we want to explore them, and we want to be a partner so that we could try to strike that balance. This isn't sustainable. We know it's not. Fee-for-service isn't sustainable. We're losing one care, and we really need to figure out a path forward, but do so that's going to maintain the financial stability of the hospitals as well. Judy, I don't know if you want to.
Yeah, I would just add that, here in Rutland, we do realize we have, somewhat of a position of strength. And with that, it allows us to be very methodical. We don't want to be reactionary and cut a service or cut a segment of our staff. It's really hard to get back if it's the wrong decision, quite frankly. It doesn't mean we're not committed. We absolutely are. And we will continue to focus on care delivery opportunities, as well as cost reduction and appropriate access for patients. If and when, at what point we think we need to come back to the board with an adjusted budget, we will absolutely do that, whether that's in a budget adjustment because our cost structure has changed, or whether we think that we need to have a conversation around particular access to care here in our Rutland community.
Well, thank you. I appreciate being able to, listen to your story and listen to your concerns. It's very helpful from where I sit now. I'll just say, I don't have any other questions, but I'd like to point out that in my prior life, your quality journey's inspiring, and I think it's illustrative that it is possible to turn things around, and you're demonstrating what it takes to do that, the type of commitment. And in my prior experience, that type of change created in a safety culture and quality turnaround, that's a harbinger of financial stabilization, mission alignment, and healthier revenues. Those follow, in my experience, with some organizations, that type of safety and quality turn. So I think you're on a great path, and I appreciate being able to hear from you each year and hear what you're struggling with. It helps us think about what we may be able to do to help you keep trying to do what you're doing. So just thank you.
I appreciate that. And we agree that quality drives performance here, and very committed to that transformation and roadmap.
Well done.
I had a question on slide 61. It's the one with the covenant compliance. The days cash on hand went from 245 in 2024 to projected 189 for 2025. And I want to understand the drivers of that. And
Absolutely.
one of the reasons I'm asking is, well, backing up, can you tell me what your total margin is projected for 2025?
Total margin for 25, I want to say, hold on, I may be a little too. Say it's maybe 5 million. Bear with me 1 second. For 2025, with the VDA, it would be a total of 30 million excess revenue over expense.
Because what I'm getting at is, I guess it's a significant decline from 245 to 189, especially if you have a total margin of $30 million. So I was trying to understand what's driving that.
I have a crosswalk that I can certainly submit to you of exactly what's going toward the downtrend in days cash. As you heard me mention in 25, we are going to be drawing on our investments. We already have been for our capital spend. That's 25 million of planned capital in that's 27.2 days right there. Also, the balloon payment and the debt payment is 8.8 million. That's another 9.6. Our cost report filing is another 2.7. I have a detailed schedule I could certainly send you if that's helpful.
Yeah, that would be helpful. And I guess same question for 25 projected to 26 budget. Again, you're anticipating a positive margin for 26 total margin. And so is it again largely capital expenditures that are driving that decrease? Yes,
that 35 million of capital spend is reducing, I believe our projections around 190 days. That's 38.3 days right there.
Got it.
And that reduction, so our investment gain roughly is another gain of 13.6 when you net those together. But we do have an outlay in a cost report for 2026. So I have like I said, a detailed schedule I'm happy to submit to you that shows you exactly the crosswalk from where we are from the 245 to the 153, 154.
If it's not too much burden on you, that'd be great.
Not at all. Okay. Absolutely. Okay.
And then you talked a little bit, I think, Ms. Fox, about clinical partnerships. And I was wondering how you identify them and which ones are, I know nothing's concrete or in the works, but if you could elaborate a little bit on what you're considering. And if it's not appropriate at this time, I respect that.
Yeah, I won't get into detail, but just to kind of leverage what Member Holmes was saying, as we're looking at services that we feel are vital and critical to our community, but services that we are having a tough time operationalizing and or supporting financially, we're looking for partners to help us out. We want to make sure that our community has all of the services that they deserve and need. But we also would like to try to make sure we can be efficient in the delivery of those services. We've had preliminary conversations with a handful of hospitals, a few hospitals here in the state, where we think we might be able to have a win-win, quite frankly, on both of our sides, and working with AHS and the regionalization of their services. And committing to those meetings that I'm hopeful will begin and take shape here soon.
Thank you. And then on the, I guess I'll call it extreme prices, the MRIs, those are really extreme. And my question is really more from a sustainability standpoint. If competition were to come in and offer those services significantly cheaper, and certainly somebody can offer them significantly cheaper, doesn't that create a significant sustainability risk to Rutland?
Absolutely.
Yes, it does.
It certainly does.
Okay. And do you have a plan to, I guess I'm worried about that reality. People are looking at Vermont, and we want them to be looking at Vermont. We want competition to drive down prices. We want care moved out of hospitals in the appropriate places, right? That is a goal of the state's healthcare reform. So is there any plan, or are you thinking about developing a plan to address and alleviate some of that reliance on extreme pricing?
Sure. So a number of opportunities before us, looking at reference-based pricing, looking at global budgeting. We need to understand what those programs look like. Our commitment to continued expense reduction, efficiency in the way we deliver. But we also need to look at how we maximize our reimbursement, particularly through our federal programs. And I'm really proud of our team this year, where they were able to bring in that volume adjustment, which is not routine reimbursement work. And so it's multifaceted. There's no one silver bullet, but it's a discipline to look at reimbursement, to look at cost structures, to look at regionalization of services, because we understand that this is not sustainable, and we are at risk.
Great, thank you. I have no other questions, and I echo the other board members' recognition of the hard work that Rutland has done to contain costs and to limit growth. We know that that's difficult, and you are one of the hospitals that have done it pretty well. The prices are high. We recognize that's a risk and a vulnerability and difficult for Vermonters, but the cost containment efforts you've made significantly outpace many of your competitors in the state. So I think you should be recognized for that, and we do appreciate your work to contain costs for Vermonters. It's important, so thank you.
Thank you.
I also understand there's a settlement proposal to the board. I'm going to work on getting that reviewed in an appropriate time for us to take a look at that. Thank you for working with our staff on addressing that. And with that, I'll turn it to the healthcare advocate for any questions or comments they may have.
Yeah, good afternoon. Just a few from us. Thank you, Rutland team, for your submission. I echo the positive comments that you've heard from board members about the clarity and the transparency in your submission. I just want to make sure I'm understanding a case that you made, I think it was on slide 56, about the impact of Act 55, which is H266, on your cost per adjusted discharge. I think you were arguing that that's going to increase those costs back to around 2023 levels, kind of eroding some of the progress you've made. Can you just talk about the logic behind that?
Sure. So the numerator, which is our expense, isn't changing, but the denominator is changing. So of course that calculation is going to look differently. And we did submit to the GMCD staff a detail of what that calculation looks like, Sam. So we're happy to walk through that further if you'd like, but that's essentially the problem, is that the expenses remain the same and the adjusted discharges would have a different calculation now because of the impact of H266. So that's what's driving that cost per adjusted discharge up.
Okay, got it. And it looks like, I think on slide 45, and you talked about this in your narrative a bit too, that your free care is coming in a bit higher than projections. So, I mean, under budgeting and maybe overperforming. I'm curious what you think led to that. And just from the analysis that we've done, that's somewhat of a historical trend for Rutland. So if you could speak a little bit more about that, that'd be great.
Well, I think it's important to point out, as we've historically had a lot of efforts around our free care program, and we keep adding resources there. So we did have 2 additional individuals become assisters this year. So we've been doing a lot of work and outreach to our patients. But also the other thing driving the free care is we're seeing a lot more patients qualifying for free care that are on high deductible plans. I'll be honest, the bronze plan in particular, obviously. Yeah. And so we've seen quite a surge lately with patients asking for free care as part of those plans. Thankfully, they've qualified. So obviously that's driving up that free care portion.
Okay. Thank you for that. And last series of questions are maybe a different frame on the executive compensation conversation. I'm curious how long you have not had variable or bonus incentive compensation.
We've ever had variable compensation here.
A long time ago. A decade or
Okay.
Years.
Okay. So, but this is not a new change, I guess is what I'm getting at. This is, okay. Because one position that I think we've heard a lot just at our office is that this type of structure, a variable pay structure, is needed to retain top talent and attract top talent. Is your position that that's not necessary to do that?
So we're really relying on benchmarking and looking at the 50th percentile. I will say that we understand that comp is an important piece of employee engagement, but we have an employer of choice strategy that we feel really committed to that wraps around other pieces of employee satisfaction and wanting to come to Rutland and stay in Rutland. Looking at, a number of onboarding, career growth opportunities, investments in leadership, how we look at safety events and, our code, our expectations for behaviors with one another. And so I wouldn't want to say it's just comp. I think we have to look at all facets of what drives engagement with employees.
Got it. Okay. Would you say that you do not need variable pay or bonuses to align with state healthcare reform goals? Like, are you able to accomplish progress towards those goals without that type of compensation?
We already have proven that.
Hello.
Thank you.
I'm not sure who that was. That was not me.
Okay.
So apologize for that.
No worries.
We're really committed to a strategic plan, and this management team recommitted with our board back in 2023, and that's what we're using to define accountability and define results, and just being committed to our community to continue to be here as a strong partner offering essential services.
Thank you, and thanks for your work.
Great. Just one clarification on slide 42. There was a note about how the ASO plans function independently of Blue Cross reserves. I think just for awareness, the ASO plans and other product lines of Blue Cross can impact their reserves. Any service line with a loss. I know what you mean. The service line has its own, but if they don't make enough money on the ASO, it will actually hurt reserves as well. I just thought I'd make a note of that. But great presentation, and thank you all very much for your hard work. I will turn it to public comment.
Hi, I'm Zachary Pratt. I live here in Rutland, Vermont. I was born in Proctor Hospital. My father was born in Rutland Hospital. My mother was born in Shrewsbury. Been around here for quite a while. So I really appreciate this board meeting and what I've learned today, listening to you all. And I want to thank Rutland Hospital because they've saved my life a number of times and my family member over quite a few years of time. So with that in mind, I'm talking to you today about UVM's Health Assistance Program. I'm not sure if you're aware or not, but as of October 1st, anybody that does not have at least one of three different criteria, and the one that I'm lacking is I do not have any UVM healthcare providers. So my prescriptions will be cut off. I'll have to pay for them, the co-pays myself. UVM has been offering them for free, which is a great service. So I've reached out to a number of people, including Vice President Reynolds, Matthew Flint up at UVM, and my primary care and a bunch of other people around town, the mayor. Because what's happening is when I get cut off, my prescriptions right now are about $10,200 copay. And I am a federal Blue Cross Blue Shield service since 2008. So I've been putting into Blue Cross Blue Shield and they've been helping me survive for all those years. So in January, Wegovy went from a $50 a month copay to a $616 a month copay. So that means Wegovy, if I were to pay out of pocket, is $7,392 a year. I cannot afford that kind of payment. And understand UVM not wanting to pay that. I was getting it from Dartmouth to begin with. So I've been asking for numbers, and I haven't been able to get numbers as to how many people in Rutland actually have UVM providers, because I don't. And to have a UVM provider for my heart, I go to Robotello and, all the local providers here. If I have to switch and find a UVM provider, I have to leave Rutland. I have to go, Brandon's maybe the closest for primary care, and then Burlington or Porter or someplace else. So that's a financial constraint. Besides, it takes years sometimes to get in to see one of these darn providers. So I did a few calculations. From what I ascertained, UVM is supporting 6,000 people under their health assistance program, which started during COVID. So that's why they're cutting back on it. So I'm assuming, not knowing what mine is, the mean, median, or mode, the $10,200 times 6,000 people is $61.2 million is what they're paying out in prescriptions, which is a lot of darn money, no doubt about it. And then you don't have the overhead, you don't have the staff, and you don't have the postage for mailing that stuff out to a person like me out here in the community. So this is a huge problem. I just wanted to bring it to the board's attention. I've been told by Mr. Reynolds that their 340B program does not support free pharmacy medications. They give it to the ambulance services, the community health services, and other people, but patients do not get it. So I understand how great care Rutland Hospital gives, but if I can't keep up with my Eliquis or my Wegovy or any of the other medicines I have, my healthcare is going to go to crap as soon as I walk out of the hospital, basically. So I don't know what can be done to help that. I understand the financial problems UVM's having, but I just wanted to share my own perspective on that. So thank you for taking the time. And if you have any questions, I'll try to answer them to my best ability. Thank you.
Thanks, Mr. Pratt, for watching the hearing and for your comment. I'm not familiar with this program myself, and so maybe just a little bit of background would actually help. You said it's a UVM Health Assistance Program, and there's 3 criteria, and they changed one of the criteria that you have to have a provider with UVM. That's the
boilerplate letter, which I can post to your website. So the 3 criteria One is the financial eligibility criteria, which I qualify for. Accurate primary prescription insurance, which is Federal Blue Cross Blue Shield. And then active care relationship with a provider within the University of Vermont Health Network. So this letter came out on June 1st, 2025. And I've been trying to find out really from a number of people exactly how many in Rutland are going to be kicked off of that program, because I think that it's going to be a tremendous impact on the community. It's not just about me. I'm not talking just about me. I'm not the only one. When I talk to my primary care provider, she says, yeah, I have a lot of people that are on that program. So I don't know what to say, but I can give you a copy of this letter. I can actually attach it to your webpage, I guess, or however to do that in the public comment section.
Yeah, that'd be great. If you don't mind, that would be helpful. Why don't you
I'd be
send it
glad
as
to
a
do
public,
that.
public comment. And we can we have a UVM hearing on next Monday. So
Okay.
we can certainly ask them. Sometimes they have representatives at like all these hearings, so there may be folks here, and maybe they can address it a little bit on Monday, or we will.
Okay.
Chair
Well,
Foster.
Please.
Could I ring in?
Yeah.
Thank you, Mr. Pratt. And no, you're not alone in your concern for this change in access to pharmaceutical medications. We are trying to work through a process, and I'm going to let Jonathan Reynolds explain how we're trying to resolve this issue for our community.
Okay.
Hi, Mr. Pratt. Thanks
Hi.
for bringing your concerns. I know we've talked electronically, but appreciate you bringing this up today. I'm sorry, I can't speak necessarily to UVM's decisions, and I'll let them opine on that. But specifically, I do want you to know that we are working on a copay assistance program for these medications, similar to what you had experienced with UVM. That it's a complex topic, but it is in contractual review. There's some federal safe harbors that we have to navigate through to ensure that we can do this. But it is something that I just want you to know Rutland Regional is actively looking at. There would be some components that we'll have to work through, but it will mirror our patient financial assistance program. But we're actively in flight of seeing how we can make that work for outpatient prescriptions. So I just wanted to give that confirmation publicly.
Well, that sounds great, because when I saw the 341B or 340B and then the 1.3 million for pharmaceuticals, I don't think that's going to cover it. Not to be funny about that, but that's the reality of prescription drugs. And I know we got a senator that's been pounding on that for a long time. So thanks for all the help you can do in getting members of Rutland community. I don't want to go to a UVM provider if I don't have to. That's for sure. Any other questions?
None from me, but anyone else for Mr. Pratt? Okay, well, great.
Okay, I'll be glad. I'll be posting this letter from UVM to your website. So
yeah.
Happy reading. That's all I can say. Thank you.
Well, thanks
nice to see you all.
Yeah, likewise, and thanks for raising it. Any other public comments?
I'm going to leave now.
Here, go ahead. Yeah, have a good night. Is there any old or new business for the board? Okay, then I will move to adjourn.
Second.
All right, all in favor, say aye.
Aye. Aye.
Aye. Thank you. Everyone have a nice evening. Good night.
We're off the record.